Hi, I'm Dr. George Bakris, Professor of Medicine and Director of the Comprehensive Hypertension Center at the University of Chicago Medicine. I'm a nephrologist and hypertension specialist, and I'm here today to give you tips on hypertension management in high-risk patients as well as the general population. So, resistant hypertension, what is it and what do we want to look for? There are new guidances in the new consensus report that will be published this summer, or I should say the summer of 2018, updating the old guideline, which was from 2008. What is new in that guideline? Well, they're going to adapt to the AHA-ACC guideline of 130/80 as the guideline. If you're above that, on 3 drugs, you have resistant hypertension. What are the 3 drugs? Well, maximally tolerated doses of a thiazide diuretic, an ACE or an ARB, and a calcium antagonist. So if you're on those 3 drugs and your blood pressure is higher than 130/80, and you do not have conditions that would lead to secondary hypertension, what are those conditions? They're endocrine conditions predominantly: primary hyperaldosteronism, pheochromocytoma, hypothyroidism. Those kinds of things need to be, or hyperthyroidism, those things need to be eliminated. Then you have to make sure the patient's taking the drugs. Just because he's on them doesn't mean he's taking them or she's taking them. So that has to be checked. And additionally, you have to make sure they don't have white coat hypertension. And so white coat hypertension is easy because blood pressures at home will be fine, blood pressures in the office are elevated. And then after all of those things, and they're sleeping properly, can you conclude that they have can you conclude that they have resistant hypertension? Of course, lifestyle factors, salt, etc., all have to be in check. And then if they have resistant hypertension, what's the 4th drug that you're going to give? Well, the new guidance is going to be that you give spironolactone, and if that's not tolerated, eplerenone. So you need a mineralocorticoid receptor blocker to be given in low doses, 25 milligrams, 50 if they're morbidly obese. And fundamentally, that's been shown in randomized placebo-controlled trials to give you better reductions in blood pressure than beta blockers or alpha blockers. So it's important with these drugs to know that the side effects related to them are dose-dependent, and that the treatment for something like primary hyperaldosteronism is 150 to 200 milligrams of spironolactone, as opposed to the resistant hypertension dose, which is 25 milligrams per day. I hope you've enjoyed this tip, and hopefully you can use it in your practice to improve patient care. Thank you and have a good day.